Okay, well, this is our second case, or patient number 2 on our respiratory virtual ward round. So this is a 74-year-old man who is known to have COPD, was admitted again yesterday with 3 days of increased breathlessness, reduced exercise tolerance from a baseline of 300 yards down to 20 yards, an increased cough compared to his baseline, and also green sputum, which is not normal for him. He's on a variety of inhalers, including Symbicort, which is a combination inhaler, which has the ingredients of an inhaled steroid along with long-acting beta-2 agonist. He's also on a salbutamol inhaler and a long-acting antimuscarinic. An example here is tiotropium. He's allergic to penicillin, having caused previous rash. He's a retired postman. No known asbestos exposure previously. He's an ex-smoker, having accumulated 40 pack years in total previously, and no pets, no bird exposure, and no family history of significance. So when he was admitted yesterday, his observations were relatively within the normal range, apart from a slightly higher respiratory rate. Otherwise, on auscultation, he had bilateral expiratory wheeze. His chest X-ray and ECG were essentially normal. His white cell count and CRP were raised. So therefore, he was diagnosed as having an infective exacerbation of COPD and commenced on treatment. The typical treatment for infective exacerbation of COPD would include obviously appropriate antibiotics, which are indicated here because of his raised white cell count, CRP, and new green sputum. Bronchodilators are part of the management here, and that may be something which we can achieve using an inhaler along with a spacer device, or alternatively nebulizers. And in some cases, we also give steroids. So again, particularly if there's evidence of wheeze or somebody's eosinophilic, suggesting underlying inflammation, then prednisolone, again, would be a useful intervention. The dose in COPD exacerbation is slightly different. We use 30 milligrams once a day than stat. And again, oral prednisolone is the steroid of choice, unless, again, patients can't take tablets for some reason. So actually coming to today on the wards, the patient, despite having been commenced on treatment for the infective exacerbation of COPD, actually has a spell on the ward today where he's got severe left-sided chest pain, which has been going on for the last 10 minutes. He's also become more breathless. So the nurse does these observations as an update, which shows that he is now a bit more tachycardic, a bit more tachypneic, and he's a bit more hypoxic as well. So the nurse asks you, really, what should you do next? So this is a scenario where you may be faced with these kind of similar things when you're working as a doctor on any ward where a patient does deteriorate following admission. Therefore, clearly it's important to go and see the patient, to see them yourself, to take a history. If the patient's alert, compos mentis, to try and get some story, try and qualify this chest pain and breathlessness a bit more, and at the same time also examine the patient to try and establish a bit more information. So if we do that, the patient describes the chest pain as actually being pleuritic, so therefore very painful on inspiration. It was quite a sharp, sudden onset. And when you examine this patient now, you notice on the left side of his left lung, essentially, he's got reduced breath sounds and a very hyper resonant percussion note. So, appropriately, next investigation to get would be an urgent chest X-ray. So we get a repeat chest X-ray. And if we just have a look at this for a moment, we can see on the left side, there really is an absence of lung markings throughout. We've got this small area here around the left hilar region, which essentially is what's remaining of the collapsed left lung. You can see this edge, which is essentially the left lung, but surrounding it, we've got an absence of of lung markings, and therefore, this is in keeping with a large left-sided pneumothorax. Now, if you just compare the right lung, we can see that there are normal lung markings throughout, and no obvious pathology on the right side. So this is an example of somebody who has a left-sided pneumothorax. So therefore, the management is going to be based on our evidence-based approach. So the first thing when we think about managing a pneumothorax, the first question is it a tension pneumothorax? In other words, is there significant mediastinal shift, which is resulting in hemodynamic instability? In other words, is the patient hypotensive? And the answer to that is no. The patient had essentially normal blood pressure. So then we're dealing with a spontaneous pneumothorax. And then the next question is it a primary or a secondary pneumothorax? So these terms refer to whether or not there is an underlying respiratory condition or not. So if there's no underlying respiratory condition or disease, then that would be termed as a primary pneumothorax. But if a patient with no underlying respiratory disease, like this patient who's got underlying COPD, then develops a spontaneous pneumothorax, that's called a secondary spontaneous pneumothorax. So in terms of management, in this patient, they had a chest drain put in, so we can see in X-ray B, this was done after they had a left-sided intercostal drain inserted. And as you can see, as a result of that, the lung is reinflated on the left side. So we've got clear lung markings now present. If you compare it to the X-ray A, where you've got that small shriveled up lung in the sort of mid-zone, now we can see in X-ray B after chest drain insertion, we've got a nice reinflated lung again. So that intervention has clearly helped this patient. This is a useful flow diagram from the BTS, which essentially goes through the management, whether you've got a primary or secondary pneumothorax. And it looks a bit complicated, but essentially in a nutshell, it suggests that if you've got a patient who's got primary pneumothorax, which is spontaneous, in other words, they don't have any underlying respiratory lung disease, you can think about doing a procedure which is essentially aspiration, and here they've described a very big size cannula. So putting a big cannula in, usually into what's called the triangle of safety in our patient, to take some air off the pleural space. So using that cannula and, for example, a three-way tap attached to it, you can aspirate up to 2.5 liters of air from the pleural space, then repeat your chest X-ray, looking to see if you've got improvement in the size of the pneumothorax and also symptomatic improvement. And if that's the case, then you may be able to discharge that patient. With a secondary pneumothorax, like our case, again, it's essentially very similar, but we generally have a much lower threshold for going straight to putting a chest drain in rather than that middle step of aspiration. But again, sometimes that may also be appropriate. In terms of oxygen, this is probably one of the few sort of respiratory indications, apart from somebody who's got, clearly, gross respiratory failure. This is one of the few occasions where high flow oxygen is actually potentially indicated, because high flow oxygen can actually help to alleviate the problem in the pneumothorax, and the problem is essentially a fistula, which is an abnormal communication that develops between the pleural space and the bronchial tree. So that's one thing to bear in mind, but obviously, again, that is only for patients who do not get oxygen sensitive. In other words, they're not getting features of carbon dioxide retention as a result of that. So there's quite a few potential risk factors for pneumothorax. As we've said already, pre-existing lung disease is a risk factor, and that's what we call secondary pneumothorax. Smoking is clearly an important risk factor, but actually, interestingly, cannabis is also associated with people having spontaneous pneumothorax. You may have read about the textbook examples of tall, thin people, and certainly height may influence the risk for pneumothorax. And in terms of other types of pneumothorax, we've got iatrogenic, which is usually following some sort of procedure, and the commonest example of that might be post-pacemaker insertion. And then clearly we've got traumatic pneumothorax, which is a very different sort of type compared to spontaneous. So what would make you suspect a tension pneumothorax, and how does management of tension pneumothorax differ to what we've described already? Well, essentially, tension pneumothorax, as I've mentioned, I think already, is when you get sort of extreme mediastinal shift, so it's a really large pneumothorax, and the consequence of that mediastinal shift, essentially pushing the mediastinum away from the side of the pneumothorax, is that it can squash some of your great vessels. So the consequence of that is you get sort of impaired return of blood back to the heart via the venous circulation. And subsequently you get a drop in your blood pressure, so you get hemodynamic instability. So essentially, if you had somebody who you suspected had a pneumothorax, or a tension pneumothorax in fact, they're likely to be somebody who's acutely unwell, very symptomatic. They are likely to be hypotensive, and when you examine them, they would have features of mediastinal shift. So that would be evidenced by tracheal deviation, and also examining their side of the pneumothorax. They would have probably absent breath sounds and a very high per resonant note or percussion note on the side of the pneumothorax. So the management of that is essentially, this is a critical emergency. So we need to decompress the tension pneumothorax straight away by using a large bore intravenous cannula into the second intercostal space in the midclavicular line. And once that's in place, again, you should potentially hear some air hissing, relief coming out, and then that gives you time, once that initial tension is relieved, to then set up to do your definitive treatment, which would be to put a chest drain in. And all of these things actually should happen without a chest X-ray. So again, for example, if you're in an admissions unit or the emergency department and somebody presents unwell, you examine them, you think they've got a pneumothorax, they're hypotensive, really that is the definition of tension pneumothorax, and therefore intervention, in other words, the midclavicular line cannula should come before the chest X-ray. Having said that, often X-rays are done for whatever reason before the intervention, so this is kind of what we call the X-ray that really should not happen. But again, it's a very good example of this large pneumothorax, which is in this patient on the right lung, and as a consequence we're getting some mediastinal shift towards the left side. This patient had a tension pneumothorax.